one thing that keeps popping up is like personality disorders versus like other diagnosable conditions. Do one of you want to kind of tackle that and like just sort of a quick primer on what is meant when you say psychiatric disorder versus a personality disorder, or axis 1 versus axis 2? Do we want to, I don't think we have to go deep into the formation of the DSM and, you know, get somebody test ready.
They got rid of the axes. Right. They flattened the axes. I mean, personality disorder, oh yeah. I mean, because it's really hard to say what's really personality, you know. Because
I'm just thinking, like, if I'm going to get an assessment and I go in and
it's a history of, it's a historical diagnosis. Borderline actually used to be if they thought somebody wasn't psychotic, just psychotic or neurotic, somewhere in between. So this is on the borderline between psychotic and neurotic, whereas a neurotic would be just anxiety problems, and psychotic would be hearing voices, seeing things that aren't there. And then borderline was kind of on the border between the two of those things.
A little bit of both.
But so personality disorder, I think of it more as it's like a combat. Everything has like a strong neurobiological correlate. So it's really not like, so to some degree, even that we call them personality disorders are really just like a historical vestige if they've been called that before. Because stuff like borderline personality disorder, that's one of the more common ones that we talk about, is highly heritable. So there's a lot of
learned or structural,
stuff.
Like it's
probably both. Yeah. Probably both. You know, it's like people that are on average much more sensitive than average and have a lot of adverse early life experiences, which can be horrific, frank trauma, or can be things that are small t trauma, but they're so sensitive that it impacted them like a big T trauma. And I agree with Casey. I don't rush to personality disorder diagnosis, not in the first couple of sessions, but it kind of, there's a natural flow to it if, you know, you can kind of start treating the anxiety, depression, that kind of stuff. And if like, there's a lot of like interpersonal issues that are just absolutely not addressed through addressing the depression and anxiety issues, it can start to be something that kind of logically comes up as a possibility when someone asks the question, well, what the heck is wrong with me? Why am I this way? You can try to some degree help them figure out why they're that way, and then there's a learned component to the behavior with personality disorders, which means that the prospect of therapy and then kind of learning in therapy and then incorporating that to learn in your life is you can also unlearn, right. like you can change the way you process things, and so that's why like borderline's an interesting one where some people have it as a longitudinal syndrome, but most people that meet the full diagnostic criteria for borderline personality disorder at time A, most people don't within 2 to 5 years, like especially if they're in treatment. I mean, people can improve. And a lot of adolescents would kind of, if you take away the fact that they're adolescent, you know, could meet the criteria for borderline or other personality disorders, but transiently as part of their adulting process.
It's funny because I worked with teenagers for a long time, and sort of one of the catchphrases that developed is that it's diagnosed as teenager, you know, and I think that speaks to that idea of like, this is not a fixed person, and in 5 years, you're going to see a different presentation, even if nothing happens, right? Like we want healthy coping skills to develop. We want healthy supports, but teenagers by nature can be emotional and can have wildly fluctuating mood states and can have an inability to moderate those mood states and can lash out as a response and damage relationships. And these are all things that show up as diagnostic criteria, right? So something that shows up in a 35-year-old is not the same as something that shows up in a 15-year-old. And that's really important to keep that in mind. Is it fair to think about these types of disorders and problems as, when I say structural, I mean like literally my brain is functioning differently than somebody else's brain in terms of dopamine production, in terms of the actual reward systems of the brain, and then the other ones are more highly developmental in that they can change over time. They can be learned and unlearned. There's more of like a behavioral component where I can affect change, whereas I can do whatever behavioral things I want. If I have a structural issue, I'm probably going to be dealing with that disorder over a longer period of time. Is that fair, or is that too limited of an understanding?
Yeah, I think that's hard. I mean, we don't really know a whole lot. Like I think we pretend we do as a whole, right? Research is ever changing. I'm thinking, I mean, Dr. Boggs, you and I shared that meta-analysis that just came out, and there's so much that goes along with this. I started my career out in homelessness, and there's the statistic: 50% of everybody that's homeless has a severe mental illness, which includes depression. You're homeless, right? Like, I'm going to be stressed. I'm going to hate life. Like, I'm not going to want to go out and do things. Like, you're probably not sleeping, maybe not due to the chemical imbalances, but probably because you're around 40 other guys, with bunks, which then leads to, lower motivation throughout the day, lower energy, which then, you know what I mean? So it just kind of keeps building on, but you take care of the homelessness and magically the depression kind of alleviates.
Right. Yeah, no, that's true. And there's probably a lot that might actually fall under the category of an adjustment disorder or an acute stress disorder, or kind of a result of life circumstances. That's there too.